Spirochetes Part 2. Spirochetes are thin, elongated, spirally coiled helical bacilli which causes an array of infections. To start with, we'll go through the classification of spirochetes. They are classified as class Spirochaetaceae and class LEPTOSPIROSIS. Under class Spirochaetaceae, we have genera Treponema and genera BORRELIA, and genera Leptospira under class LEPTOSPIROSIS. Under genera Treponema, we have Treponema pallidum, subspecies pallidum, which you have already studied in Spirochetes Part 1. Today we will go through Treponema pallidum, subspecies Pertenue, subspecies Endemicum, and Treponema cariatium. And also we will go through genera Borrelia and genera Leptospira. So Treponema Pertenue, Endemicum, and cariatium cause a group of disease called non-venereal trypanomatosis. These are yaws, endemic syphilis, and pinta. How are they different from venereal syphilis? One is mode of transmission. These diseases are transmitted non-venereally, hence the name, and the mode of transmission is mainly by touch or contact. The age of acquisition is usually in childhood rather than adulthood, as in case of syphilis. These are usually found in the rural areas of developing nations and also among travelers to these countries. It is associated with poor hygiene and low socio-economic condition. We will go to the clinical features in the slides ahead. So yes, this is more common in areas of Africa, Southeast Asia, and Central America. It's endemic in about 13 countries. In India, we find yaws in tribal areas of Odisha, Chhattisgarh, Assam, Andhra Pradesh, and Madhya Pradesh. As I already told, it is transmitted by direct skin-to-skin contact. The incubation period is about 3 to 4 weeks, and clinical manifestation is in the form of extragenital papule, also called as mother yaws. So as you can see in this picture, there are ulcerative lesions on the extremities. There can also be papillomatous lesions on the face. There can be regional lymphadenopathy and periostitis which cause severe nocturnal bone pain. And WHO is aiming for global eradication by 2020, and it has taken measures to go ahead with this eradication. The next one is endemic syphilis. It's also called as Bijal. It's endemic in dry areas of Asia and Australia. Again, transmission is by direct contact, kissing, or by sharing the same utensils. It manifests as an oral papule, which can be in the form of mucosal patches, which is very similar to the condylomata lata of syphilis. So you can see these lesions, mucosal patches on the face of a patient with endemic syphilis. The lesions can be destructive later on. There can be destruction of the gummas. There can be osteitis, which are more common in late syphilis, endemic syphilis. The next one is pinta. Pinta is more common in Central America and South America, and it is transmitted by direct contact. There can be pruritic papules on the face and extremities. So these are the lesions of pinta. There can be what is called as pintitides, which are deeply pigmented patches that are pruritic lesions, and they are infectious, which can persist for a long time. And there can also be dyschromic macules on the skin in the later years, which contain plenty of bacilli. So the diagnosis of these non-venereal trypanomatosis is very much similar to syphilis. The serological test what we use for syphilis holds good for NVT also. Coming to treatment, yaws can be treated with a single dose of azithromycin or a single IM injection of benzathine penicillin. And endemic syphilis and pinta, both patients and contacts can be treated with injection of benzathine penicillin. Coming to the next organism, that is Borrelia. Most of the species of Borrelia are commensals on the buccal mucosa and genital mucosa. However, few of them are pathogenic. So in this we have 3 species: Borrelia recurrentis, which causes relapsing fever; Borrelia burgdorferi, causing Lyme disease; and Borrelia vincenti, causing Vincent's angina. So now we'll go through the transmitting agents. So as you can see, what this is louse and this is tick. Epidemic relapsing fever is caused by Borrelia recurrentis and louse, the human body louse or the head louse, they act as the transmitting agents. An endemic relapsing fever caused by Borrelia duttoni or Borrelia hermesi is transmitted by tick. Coming to the pathogenesis, so epidemic relapsing fever is caused by crushing of human body louse by scratching. So when there is infestation by body louse, naturally there will be scratching. So when one scratches these louse, there will be deposition of the infected hemolymph which contain the spirochetes, because that will be released from the body of the louse. These organisms will go into the blood and disseminate in the blood, causing epidemic relapsing fever. Endemic relapsing fever is caused by bite of the infected tick. So from the inoculated site, the Borrelia spreads rapidly, causing bacteremia and fever. So one can ask why the body's defense mechanism cannot eliminate the antigen. The answer for this is the antigenic variation. So these borrelial surface antigens are known to undergo frequent antigenic variation, and each time new antigens are produced on its body which can evade the immune system of the host. So that leads to repeated infection, repeated febrile episodes and also bacteremia. Coming to the clinical features, incubation period is about 7 to 8 days. There is history of recurrent fever episodes, and there are many non-specific symptoms like pain, abdominal pain, vomiting, diarrhea, altered sensorium. There can also be hemorrhages in the form of petechiae, epistaxis, and also blood-tinged sputum. There can be neurological features like meningitis, seizure, focal deficits and psychosis. These two conditions are more common in epidemic relapsing fever. Coming to the lab diagnosis and treatment, the blood is the most commonly used sample, and these organisms can be identified by microscopy. As you can see, these are the spiral organisms seen under microscopy. They are about 10 to 30 millimeter in length and 0.2 to 0.5 micrometer in breadth. You can identify or you can recognize that there are less number of spirals and they are wider. Coming to staining procedures, these organisms can be stained by gram staining. Their gram reaction would be poorly gram negative, and peripheral smear can be done. It can be thick or thin smear, and they can be stained by Wright stain or Giemsa stain. The other method is direct fluorescent antibody test using monoclonal antibody. Dark ground microscopy can also be done, but it has got a low sensitivity. Quantitative Buffy coat has got a very high sensitivity, and because they are very thin, they are better viewed by silver impregnation method also. So during afebrile period, when the microscopy cannot identify the organisms, culture can be done for confirmation. Then serology, ELISA and indirect fluorescent antibody test can be done to detect the antibodies. So when there is a 4-fold rise in the titer, it is considered as a significant titer. The other methods are the molecular methods. They can be real-time multiplex PCR and other types of PCRs which can be done to identify these organisms. The target site would be 16S rRNA and GLPQ genes which can be identified through the PCR. Treatment is mainly by giving doxycycline or erythromycin in single dose for epidemic relapsing fever and 7 to 10 days for endemic relapsing fever. The next disease we'll be going through is Lyme disease. So in 1982, Willy Burgdorfer was the first person who linked this disease to spirochetes. The epidemiology of this disease is as such. Rodents and deer are the animals which serve as reservoirs of this disease. It is widespread in USA, and Borrelia burgdorferi is the common organism implicated. And in Asia, Borrelia gardini and Borrelia afzeli are more common. So this disease is transmitted by Ixodes resinus tick. Pathogenesis of Lyme disease. So when the spirochetes enter into the tick, it expresses an outer surface protein on its surface in order to survive inside the tick. And then spirochetes goes to the salivary gland of the tick, where it expresses another protein which binds to the tick salivary gland protein, and this is the crucial step for transmission of the disease. So in order to transmit the disease, tick must attach for 24 hours onto the spirochete. Coming to the clinical features, the incubation period is about 3 to 32 days. So the stage 1 is called as early localized infection. So here you can see annulo-maculopapillar lesions which develops at the site of tick bite. So you can see these annular lesions on the skin. This is called as erythema migrans. The most common sites are thigh, groin and axilla. It is seen in about 20% of the cases. In stage 2, there is early disseminated infection. So within days, there is hematogenous spread to many diseases. There can be secondary annular skin lesions, there can be arthralgia, there can be profound malaise and fatigue, and also neurological abnormalities and cardiac involvement. Stage 3 is the late persistent infection, also called as LYME arthritis. About 60% of the patients develop arthritis of the large joints, especially knees, which can last for weeks or months. Some patients also complain of acrodermatitis chronica atropicans, which is a late skin manifestations most commonly seen in elderly women. So post-Lyme disease, here we see chronic fatigue and cognitive deficits in some patients. Coming to the lab diagnosis, the samples most commonly utilized are blood, CSF and scrapings from the skin lesions. BSK medium, that is Barbour-Stoner-Kelly medium, is the most commonly used culture medium. After incubation at 34 degrees centigrade, organisms are examined under dark field microscope weekly for up to 2 months. Only after 2 months we can give a negative report. Under molecular methods, we have PCR, which has a very good yield in joint fluid, but the sensitivity is poor in CSF, blood or urine samples. And the most common targets are FLA-B and outer surface protein A. Okay, then serology. Antibody detection is the most commonly used method. ELISA and Western blot are employed to detect the IgG and IgM antibody. So we look for a 4-fold rise in antibody titer at an interval of 2 to 3 weeks, which is considered as significant titer. So CDC recommends a 2-test approach wherein we have to do ELISA at the first place, and if it is positive, we have to confirm it by Western blot. And other tests like CBC can be done, which yields an increased WBC count in the joint fluid and lymphocytosis in CSF. And the treatment is oral doxycycline for adults and amoxicillin for children. And the duration of this treatment depends on the type of infection. The other disease is Vincent's angina. It's also called as trench mouth. It is an ulcerative gingivostomatitis or oropharyngitis caused by Borrelia vincenti along with Leptotrichia bacchalis. So it's a polymicrobial infection. Inflamed pharyngeal mucosa is seen with grayish mucous membrane which peels off easily. So you can see that there is a grayish mucous membrane and also inflamed gums, and this patch can be peeled off easily. Though it's a normal buccal flora, it can cause disease in presence of malnutrition. So here this is a gram stain demonstrating the spirochetes and also the fusiform bacilli, which you can see in the smear. Treatment is mainly by penicillin and metronidazole. And the last one is leptospirosis. It is a zoonotic disease. It's also called as Wales disease. The incidence of leptospirosis is about 10 to 100 per 10,000 per year in tropical countries. And it's worldwide in distribution, and highest burden is seen in Brazil, India and Thailand. In India, the most common regions where it is seen are the coastal areas of Andaman and Nicobar, Gujarat, Kerala, Maharashtra, Tamil Nadu and Andhra Pradesh. The causative agent is Leptospira interrogans. It is the pathogenic species. The other species are Leptospira biflexa, which is a saprophyte. There are actually about 26 serogroups based on agglutination with specific antisera, which further consists of over 300 serovars. So we have serogroups of Icterohemorrhagiae, which has several serovars like Icterohemorrhagiae, Coaphagiinae, Lai and Nam, and still several serogroups are being discovered. But the pathogenic ones we are going to study is about Leptospira interrogans. So the source of this Leptospira is in rats, dogs, cattle and pigs. So the urine of the asymptomatic animals can also transmit the infection. So who are at risk of acquiring leptospirosis? They are the agricultural workers, fishermen and sewer workers, because they come in, the agricultural workers come in contact with the cattle and pigs, and sewer workers and fishermen come in contact with the urine of rats while cleaning the sewage. Epidemiology of leptospirosis. So seasonality is a very important factor in the epidemiology. It's more common in rainy season and also in urban and rural slums. So these three, rodents, rainfall and rice field, these are the three epidemiological determinants, the three R's, which are vital in the causation of leptospirosis. The mode of transmission is by indirect contact with water, moist soil and wet surface which is contaminated with animal urine. So direct contact with urine and parturition products, which is seen in case of veterinary doctors or the agricultural farmers, it's more common in this group of people. Now coming to pathogenesis, there are two phases. One is septicemic phase, the other one is immune phase. In septicemic phase, the organism first enters through the abraded skin or abraded mucosa or maybe intact mucosa also. Then they spread hematogenously to various organs and cause vascular damage. So how do they cause the tissue damage? It is mainly by release of the enzyme hyaluronidase, which is responsible for causing tissue damage. In the immune phase, we see the development of antibodies. So these antigen antibody complexes deposit in various organs. The bacilli also adheres to the renal tubules and these organisms are thus excreted in the urine. This is called renal colonization, wherein they become adherent to the proximal renal tubular brush border and then excreted in the urine. Coming to the clinical features, the incubation period is about 4 to 20 days. There are two phases. One is mild and icteric febrile illness. This is seen in 90% of the cases. And the second one is Weil's disease, which is seen in about 10% of the cases, wherein we see hepatorenal hemorrhagic syndrome. Here, severe icterus is seen, and this is severe and fulminant form of disease. Coming to the lab diagnosis, the samples collected are CSF, blood and urine. So, what are all the modalities available? They are microscopy, culture, serology, molecular methods and animal inoculation. Coming to the microscopy, so wet films are used to identify the organisms. Either dark ground or phase contrast microscopy is used. So you can see the organisms, the spiral organisms in the dark ground microscopy. As these are very thin organisms, silver impregnation technique can be used, and Fontana stain and modified stainer techniques are the techniques used. They are about 6 to 12 micrometer long and 0.1 micrometer wide. Coming to the morphology, they are about 6 to 12 micrometer long and they are tightly and regularly coiled, and you can see a hooked umbrella like handle at the ends. So this is very characteristic of Leptospira. So in the slides, the spirochetes, different spirochetes are identified by the Leptospira is identified by the appearance of the hooked umbrella, which is not present in Treponema. These are highly motile. The disadvantages of microscopy are that it is less sensitive and many times artifacts are seen, which is difficult to differentiate from the organisms, and also it needs technical expertise. Culture. This organism is an obligate aerobe and a slow grower. It needs an incubation period of about 4 to 6 weeks at 30 degrees centigrade with a pH of 7.2 to 7.5. After incubation, cultures have to be examined on first, third and fifth day, then followed by weekly intervals. And negative report can be given only after 6 weeks. The culture media used is EMJH media, and we can see, so you in this picture you can see the formation of a ring at the junction of this liquid. This is called as Dinger's ring, and in this Dinger's ring you can see the organisms. If you take the liquid, it's a liquid media. So from this, if you take the liquid and view it under the microscope, you will see the organisms. Other medium used are Korthoff's medium and Fletcher's medium. Advantages of this method are that it is confirmatory and it is useful for stock maintenance. But the disadvantages are that it is a very laborious procedure and there are chances of getting false positive and false negative reports. Animal inoculation, hamsters are the animals used which are 4 to 6 week old. Young guinea pigs can also be used. After they are inoculated, their peritoneal fluid is to be examined. Serological tests are the gold standard methods which are used for diagnosis of leptospirosis. They can be used for antibody detection and to detect the cross-relatedness between these strains. Coming to the antibody detection. IgM antibodies appear within 1 week and reach a peak in 3rd or 4th week. After that, they decline slowly and within 6 months they become undetectable. IgG appears late in the disease, reaches a peak after a few weeks. It can persist for many years. So, antibody detection, under this we have genus specific tests and serovar specific tests. So, under genus specific test, so these tests can detect only reactive genus specific antigen which is prepared from non-pathogenic strain. So, under this we have microscopic slide agglutination tests, latex agglutination test, ELISA and ICT, immunochromatographic tests. But these tests cannot detect infecting serovars. The other one is serovar specific test, that is microscopic agglutination test or MAT. These detect the antibodies against a specific serovars of Leptospira interrogans. This is the one which is most commonly used. This is the gold standard and a reference test. Here, the serum of patient is mixed with live antigen of endemic serovar on a microtiter plate. Then it is examined after 2 to 4 hours under dark ground microscope. Coming to the molecular methods, PCR is used, which is useful in severe disease and also before seroconversion, but it is not serovar specific. The other non-specific findings could be elevated blood urea nitrogen, elevated serum creatinine and altered liver enzymes. Coming to the prevention and treatment, whole cell vaccine is available which is given as a subcutaneous injection as 2 doses at 15 days interval. Third dose is given after 4 to 6 months. Efficacy is about 60 to 100%. Chemoprophylaxis can be given with doxycycline for short-term exposure. And other preventive methods are having a better sanitation and providing the glove and the gumboot for the sewer workers who are more exposed, and even the veterinary doctors and the farmers should take utmost precaution while dealing with the animals. Rodent control should be done and health education should be given to all the at-risk groups or at-risk group of patients in terms of how to control the infection. Treatment. Mild leptospirosis can be treated with oral doxycycline 100 mg BD for 7 days. Severe leptospirosis can be treated with penicillin 1.5 million units 4 times a day, or ceftriaxone or cefotaxime can also be used. Thank you.